Kim is has a master's in public health from the University of Texas and has worked in public health for 3 decades. During this time, she has been a state health planner, health educator, grant writer, and manager, clinic manager, and program manager. She's worked extensively with homeless populations and providing outreach to hard-to-reach populations. For the last 4 years, she has been working in Multnomah County Environmental Health in Oregon, where she managed the Healthy Homes and Families program. These programs include Healthy Homes, CARE, which she'll explain, and AIR programs, which provide case management for families with asthma and other environmentally triggered health conditions. Healthy Homes and CARE began as a HUD Healthy Home Demonstration Grant and include home environmental assessment as well as nursing case management over approximately a 6-month time frame. In 2010, Multnomah County created the Targeted Case Management Healthy Homes program to secure Medicaid reimbursement for home asthma visits. And we'll get Kim started here. Everybody cross your fingers.
Okay, so again, I'm an attorney from Multnomah County, Portland, Oregon. Environmental program. Okay, so we have a number of programs. We have a number of programs with our Healthy Homes program that started in 2005 with the Healthy Homes Demonstration Grant. And that program was primarily a nursing and environmental case management program that lasted for about 6 months. It was medical referrals from medical providers into that program. And we started out serving just really young children, but we expanded up through the age of 18. 2009, we started the AIR program, which was similar to the Boston Breathe Easy program. It's a one-time visit by the environmental health inspector. There's no income limit for these families, and what we saw is that families that came in with less severe asthma didn't really need the 6-month case management, so we referred them to the AIR program. We also looked at making some policy changes. So in 2009, at the same time, we implemented a housing code for Multnomah County and hired a rental housing inspector to do rental housing inspections, and that was covered through our general fund dollars. In 2009, we applied for the Healthy Homes Demonstration Grant, which we received and implemented in 2010, and we called that the CARE Grant. That is ending up now. We're in a no-cost extension, and we're serving children. I think of this program as kind of Healthy Homes on steroids, because it's not just serving children with asthma, but also other environmentally caused health conditions. It also provides physical home repair and does not require that a person is referred by a medical provider. There also, so we take referrals from community providers and we access people into medical care. And then we also have a lead poisoning prevention program. So this is kind of the flow of somebody that's getting referred into our program. We have a web-based referral system, and again, we've expanded beyond just referrals from medical providers. We also take referrals from community-based organizations, Head Starts, WICS, etc., and other social service providers. So if somebody will make a referral into the program, our intake specialist then triages them into whichever program works best for them. If they are over income or they have low-level asthma, they'd go to the AIR program. If the asthma is more severe, they'd go to the Healthy Homes program. And if they have either less severe programs, they have housing issues, they have something that is not quite asthma, but it is related, like really bad eczema, skin conditions, respiratory distress that isn't defined as asthma yet, then they would go into the CARE program. And the CARE program is a little different than the Healthy Homes, and the Healthy Homes is nursing case managed. But the CARE program is a community health worker case managed, and when they come in, they do an assessment in the beginning. They determine this person needs a nurse, they'll refer to the nurse. This family needs home repair that's more extensive, they'll refer to the environmental health specialist who will facilitate that. Okay, so this is just... Okay, so CARE is unique in a number of ways. We hire people, we actually have we're using a couple of community-based organizations that actually have hired community health workers, and they're part of our multidisciplinary team, and that has an advantage in that we are able to tap resources in those community-based organizations that might otherwise be a little difficult for us to tap. We have a web-based referral and data system, so we can share data. It's basically an EHR, but we use iPads in the field, and we'll do all of our assessment and charting and communication through the iPads. We have partners like the City of Portland who provides money for home repair. So we have about $75,000 a year in small home repair through CDBG grant money. We have our community health department who provides primary care services and provides medical homes to 40 families a year who may not have access to medical care. Again, our health issues are broader than just asthma. We do team case management through the web system, through because it's kind of hard to have a paper chart and have 4 or 5 people dipping into it. And then our interventions are expanded beyond air quality, which was what our Healthy Homes program looked at, and we're looking at safety issues and hazards as well. So this is just a diagram of our partners and how we tap these various agencies for various things. Okay. Well, actually, our social services agencies and partner agencies have expanded. This was at the beginning of the grant. We probably have close to 90 different agencies that are tapped in that are referring to us, that are on our agency list. And then, again, the physical home repair, and then the City of Portland also has a lead hazard and abatement program that we tap and refer people, and we don't do that ourselves. Okay, so that is basically talking about kind of our program as it is. I wanted to talk a little bit about the targeted case management. In 2005, when we got the grant, one of the things that we did was we started gathering data at that point to be able to demonstrate return on investment. So we built certain things that we were going to measure. At that time, what the things we were measuring were the medication ratio of control to rescue meds. We looked at ACT scores, we looked at hospitalizations in ER, and we looked at environmental score. So we used that to basically build a case when we ran out of money, when the grant ended. And we decided that we would look for some way to try to sustain our funding. And what we ended up doing when we tried a number of different things that didn't work is we ended up working with DMAP to develop a targeted case management program specifically for healthy homes. This required a lot of work, probably about 2 years of work in terms of just building the case for it. A lot of that was getting in front of the media, trying to look for opportunities to get public service announcements out there, stories about our work, etc. Try to get try to get the information out about people, about our program. We got testimonies from families. They would come and they would present to legislators. They would come and speak to our groups. We'd have little stories that they would write up and include. We developed our own book, but this was based on actually a book that it's basically credited to the University of Massachusetts and the Asthma Regional Council in New England, who actually developed kind of the template for this book, and we adapted it for our purposes and put in our return on investment information into it. And one of the big ones for us is that we were able to demonstrate a 2.5-time reduction in ER visits. So that was a big one that indicated a lot of savings from the program. So about a year before we actually were able to implement the TCM, we finally we were meeting with the managed care providers, trying to convince them to try to fund the program. Not having a lot of luck with that. We had politicians that would gather all the stakeholders together and try to give us an opportunity for selling our message. But then we identified a champion within our DMAP, which is our Department of Medical Assistance Programs, who saw the light, and she got on board and started really pushing to have this happen. And with her support, we started looking at all the work kind of done at a national level. We looked at targeted case management. Would that model work for us? And we decided it would. And we adapted our program so it fit within the TCM model. And I'll show that, explain that to you in a little bit. And then we started, within about a year, we started looking at a timeline, developed a plan, what had to be done, because we had to be able to demonstrate that we were going to have TCM in place by the next fiscal year so that we continue to have funding. Then what we looked at doing was we took the state plan amendment, or the SPA as it's referred to, and we adapted it to basically wrote our own targeted case management model and wrote it with the state jointly. And we had to do some time studies during that time and determine which of our activities were billable or not billable, what time was spent doing those activities. We then identified kind of what the rate was, what was the allowable rate, what things we could include, what things we couldn't include, how we bill out for services. And then in September of 2010, it was basically approved. And we had to negotiate with CMS. The actually starting TCM was another step in the process. And so in doing that, we had to develop our targeted case management forms that fit for assessment, etc. We had to have standards, we had to have audit criteria. We developed a billing system and how we were going to bill the state for these particular things, our own codes. We had to provide quarterly time studies, which we still do because we use those time studies to negotiate our rates. And one of the things that we found when we implemented this program is because of all the additional paperwork for targeted case management specifically, is that we weren't able to keep our productivity up like we had done before. And our cost per visits went up, our productivity kind of went down. One of the things that we had hoped to do was really evaluate the program with help from the state. And we do evaluate the program, we've got those same things in place, but the state hasn't been able to provide their part of that. So they haven't been able to provide the data so that we can get it from the state to demonstrate our success, but we're doing that on our own. So this is the risk criteria that we wrote up in the SPA. It is, but I want to point out that they are not limited to having one of these risks in order to participate in our program. When you were talking to her earlier about the high-risk folks, I think these criteria are the kind of things that you'd be looking at that you would want for referrals. And this was kind of developed for kind of a statewide process. But one of the things we wanted to have the flexibility that if people made a referral to our program and they had asthma, an asthma diagnosis, that they'd be able to get those services, and that could be a judgment call based on the provider working with the family, whether or not the care plan was met or not. Okay, for targeted case management, we have 5 different types of things that we can be reimbursed for. These are the description of services, comprehensive assessment, development of the specific care plan, monitoring follow-up, linking and referral, and reassessment. And you'll have a copy of the SPA. This is out of the SPA. You'll have a copy of the SPA and the materials that you get on the jump drops. But to give you an example of the things that we wrote into each of these different types of activities, and this is how we adapted it for Healthy Homes, we included that the evaluation of the extent and nature of the recipient's needs, and we included medical, social, educational, housing, environmental, including assessment for lead exposure and existence of secondhand smoke and other specified asthma triggers and irritants. So that's the kind of thing that we did to adapt it to our particular program, okay? And we did that for each one of those areas. One of the things that was important for us is that we have a community health worker working with the program, and we wanted to be able to bill for her services. Now, there are very few community health workers in the state of Oregon that are able to bill for services. And so we wrote it into the SPA, and it was approved by CMS to be able to do that. But one of the things that we did was we said if they're certified as a chronic, under the standard chronic disease model as an educator, or they have an asthma educator, then they'd be able to be reimbursed. Okay, going on there. Okay, these are the kind of things. One of the things, these are the things that we manage for the most part over the course of the programs. Emergency room visits, hospitalization, medication ratio, we control the rescue events. We haven't been doing that one lately because we didn't think we could get the support from our DMAP program on that. Changing the environmental scores. ACT scores are the things we've measured, but we're thinking about starting to look at track scores, which is for younger kids. And quality of life questions, which we have added. Work or school days lost is one that CDC has really pushed people to try to measure. We haven't been able to figure out a way to capture that one. Okay, so I'll just tell you the rest. So some of the lessons learned from this is that CDBG was able to give us some money for home repair. We were able to get medical homes for families that didn't have them, which I think is really critical that they have access. One of the things that we were able to do as a result of this is we could use the program income in our current grant as we could use the targeted case management money, the Medicaid dollars, as ways to supplement our current grant. So there's a lot of money that our nurse brought in from her nursing visits to be able to supplement and extend the services in our current grant substantially. So that was helpful. We really underestimated the need, especially with our new grant. It was a lot more extensive than just healthy homes. Okay, I'm actually going back to the tracks. Okay. The outstation staff thing approach worked really well in terms of being able to tap a lot of resources that we otherwise wouldn't be able to tap. And because we've had two programs going on at the same time, we've been able to see what are the pros and cons for both programs and be able to compare that. And we're still in the process of analyzing that, but we've been gathering a bunch of data, which I'm not going to have time to cover. And then some of the challenges. The new technology, the use of iPads in the field, putting together a data system have all been really challenging, but there have been pros and cons with both of those things. Personally, I think the iPad had worked really well, but not everybody is going to be an early adapter in terms of that. So we had a kind of a real range of people on our staff. Some people that didn't even want to touch the things, and the others who thought that they were the greatest things since sliced bread. Enrollment has been an issue for us, not because we haven't gotten a large number of referrals, but because once we got the referrals, we had to try to get in touch with the families. And what we found is a lot of folks, their phones, you guys are hearing me, aren't you? Okay, yeah, so their phones were disconnected, they were turned off. We started texting people as opposed to calling them. It was amazing. You could call somebody, you turn around and text them. 5 minutes later, they respond to your text, won't respond to your phone call. But that was a challenge. Partner timelines. Some of the partners, especially around remodeling and physical remediation that worked with us, had different timelines. Maybe it'd take a year to get something done but they'd repair a roof, so you didn't want to, but they have different timelines. Scope of the community health workers. We probably put too much work on the community health workers. They were doing a lot of stuff, and it required a lot of supervision and assistance. Charting was a challenge. Caseload management, because the need was greater, the caseloads grew as opposed to being able to be done in 6 months. And in Oregon, we have some unique landlord-tenant issues. It's really a landlord's market, and people can be evicted with no cause of eviction. And we had a lot of folks that were very scared to talk to their landlords, justifiably so, to get corrections made on their housing. And then these are the various slides where we're comparing the two programs, and that'll be in your data.
Kim? Sure. Do we have June on the phone?
I'm here, can you hear me?
Yes, thank you. So, June, I'm going to turn over do you have a computer available?
I do,
Okay, and are you looking at the GoToMeeting screen then?
yeah.
Okay, I can make you the presenter if you want to bring up your PowerPoint. I have it here, but we're going to try and let you control it here.
So do I just bring it up on my computer screen?
Yes,
Oh, show my screen, okay.
you are now the presenter, so your screen should show up.